I know I put people on the spot, and I apologize, but I just think it's important that everybody gets to know everybody as we kind of keep moving on, especially as we're starting to see some new faces. So today we're going to cover multi-system stuff, so thank you to everybody who submitted questions. I went through them last night and this morning, and so hopefully today's stuff will be helpful in trying to answer some of the questions you guys have lingering from the study session on multi-system. So I'm going to send this PowerPoint to everybody through Google Classroom, but I thought some of the images on here were super helpful for trying to break stuff down and put it in really easy charts that you can print, that you could memorize if you're so inclined to do that, or even just things that you can scroll down when you get into the testing room, little charts that you can just write down on your scrap paper to help you remember certain things. So when we're talking about shock states, there was a question about afterload and preload. So I've got this that I pulled up from Emergency Medicine in 5 that gives you a good background as to what you should be expecting for your patients, preload, afterload, and perfusion based on what sort of shock state they're in. So it gives you the several different types of shock states, your pulmonary wedge pressure, CVP, your cardiac output, systemic vascular resistance, and then your O2 sat, depending on what sort of shock that your patient's experiencing. So this is just to answer one of those questions about preload versus afterload. I thought this was very helpful. And when we get to the pharmacology part a little bit later, I have which medications impact preload and afterload when it comes to pressors, because that was another one of the questions. This I found really helpful when you're actually doing the assessment on your patient and you're kind of looking at what sort of shock your patient's in. So it goes through the different components of the hemodynamic profile. So you might not be able to get a wedge pressure, or occlusion pressure, or an SVR if your patient doesn't have a SWAN, but you should be able to get at least a heart rate, blood pressure, MAP, and CVP on most of our patients in critical care. And then if you're up on 7 Southeast, you can use the Cheetah to get the cardiac output. So while I know everybody's studying for the CCRN, I actually thought this was helpful just for general practice in looking at shock states in your patient. And if you get familiar with this chart and you have to answer what sort of shock do you think the patient's in on the CCRN exam, this is kind of a helpful thing to have in your back pocket as far as tools go. And so I'll make sure that you guys get this PowerPoint at the end of today, so that way you can print these out or copy them or whatever way you study best. There was a question about the different phases of septic shock, and I'm hoping this will show up. Hold on one second. Try this one more time.
Moving on from hypovolemic and hemorrhagic shock, we're going to move into sepsis and septic shock. So this is the #1 cause of death
you guys hear that okay?
in cardiac ICUs. Mortality rates in the United States are well over 200,000 deaths each year. And you want to know the difference between the stages of septic shock, not the phases of shock, but the stages of sepsis and septic shock. First, you have sepsis and septic shock. You have the systemic inflammatory response syndrome, SIRS. Then further progressing, you're going to move into sepsis, severe sepsis, septic shock, and then multiple organ dysfunction syndrome, MODS. So each step builds on each other. That, for example, 1 will lead to 2, 2 will lead to 3, 3 will lead to 4, and so on. For the first stage in response, for the systemic inflammatory response system, this is a system response with at least 2 or more of the following: heart rate greater than 90, a temp greater than 38 degrees Celsius, which is 100.5, or a temp that is less than 36 degrees Celsius or less than 96.8 Fahrenheit, a respiratory rate of 20 or greater, or a PaCO2 level of less than 32. This is going to be related to that respiratory alkalosis, that early phase of shock. White blood cell count greater than 12,000, or a white blood cell count less than 4,000, or just a shift in the bands to the left, which can signify an infection. It's important to note that a patient may have SIRS without sepsis related to a non-infectious injury such as burns or pancreatitis. That's why we call the systemic inflammatory response system the first stage before sepsis. So, moving on to sepsis. The criteria for sepsis is the same as SIRS: 2 or more factors, again listed there, plus a suspected infection or documented infection. You need positive blood cultures from blood, sputum, or urine. You want to be having a patient on antibiotics or other anti-infective therapy. You can have altered mental status, infected wounds, immunosuppression, pressure ulcers, urinary catheters, lung infiltrates on an x-ray, which could mean possible pneumonia. So you can have the two qualifiers for SEERS above, plus a suspected or documented infection, and that's what you can call sepsis. Remember, in sepsis, there's no organ dysfunction. So moving on from sepsis to severe sepsis, this is the presentation of severe sepsis, which includes all of those of sepsis, plus the signs of organ dysfunction. So you have the two signs of the systemic inflammatory response system, plus a suspected infection, and signs of organ dysfunction. So examples of organ dysfunction include an acute drop in urine output, acute hypoxemia, hypotension, mental status changes, lactate greater than 2.0. This is the anaerobic metabolism leading to lactic acid, which is showing you there is a decrease in oxygenation leading to less aerobic metabolism. Platelets below 100,000, or again, coagulopathy. There are signs of organ dysfunction in severe sepsis. In normal sepsis, there is no organ dysfunction. Moving on from severe sepsis to septic shock. This is the presentation of septic shock is all of those in severe sepsis plus one or both of the following: a MAP of less than 65 while giving adequate fluid resuscitation, or when adding a pressor drug such as norepinephrine to maintain the MAP of greater than 65 plus the fluids. Remember, there's a process that keeps building up and not just one single episode. So systemic inflammatory response goes to sepsis, to severe sepsis, and then to septic shock. So the last stage of septic shock and severe sepsis is multi-organ system dysfunction, MODS. So the progression from septic shock into worsening organ dysfunction. This comes in several degrees of severity, but in general, develops from the dysfunction of two or more organs, from slightly to severe, all the way to severe organ failure that is irreversible. This can continue to develop in two or more organs with the same degrees of dysfunction, that is ultimately leading to 80% of deaths in the ICU settings. Some of the signs of multiple organ dysfunction syndrome by organ system I have here. Neurologic, you can have delirium confusion in others. In cardiovascular, you can have tachycardia, dysrhythmias, decreased systemic vascular resistance, elevated troponin level. Pulmonary, you can have tachypnea, dyspnea, hypoxemia. Hepatic, you can have elevated liver function tests, hypoglycemia, jaundice. In the renal, you can have decreased GFR, oliguria, elevated creatinine. Metabolic, you can have, again, metabolic acidosis, elevated lactate due to the anaerobic metabolism. Hematologic changes include coagulopathy, thrombocytopenia, increased D-dimer levels. And under endocrine, you can have adrenal insufficiency and hypoglycemia or hyperglycemia. In sepsis or septic shock, you want to prevent MODS. This is the last stage. So since MODS has such a high mortality rate, especially in the ICU setting, we want to identify signs and symptoms prior to the patient developing MODS in order to treat the patient as early as possible. Remember, sepsis, severe sepsis, and septic shock is what you need to focus on in this video. First, let's see what you know. We're going to differentiate between sepsis, severe sepsis, and septic shock in a real-world example by the following. Number 1, the patient's blood pressure is 76/36. After receiving a 500 ml fluid bolus, the BP came to 100/56, so it was responsive to fluids. The ABG shows 7.31, an elevated lactate at 4.1, a base excess of -5, and the patient has an acute abdomen. So what's your answer for that? You can pause the video if you need more time. Number 2, the patient's blood pressure is 78/38. After receiving a 2,000 ml fluid bolus, the blood pressure came to 86/46. So even though there was giving more fluid, the blood pressure was less responsive. The ABG reveals pH of 7.31, an elevated lactate at 4.0, with the same base excess. So what do you think the answer is for that? Sepsis, severe sepsis, or septic shock? Again, if you need more time, pause the video. Number 3, The patient's blood pressure is 108/78. The ABG reveals a pH level of 7.33, a lactate of 2, a temperature of 38.9 degrees Celsius, which is 101.5, and a white blood cell count of 15,000. This patient also has an acute abdomen. So you think you have the signs of the elevated temperature, the elevated white cell count, fairly normal blood pressure, but an altered ABG. So what do you think that answer is?
Does anybody actually want to share their answers? If not, I'm going to give you the correct answers in the next slide. Silence is deafening.
So number 1, severe sepsis. This is because of the beginning, the signs of organ dysfunction, such as the low blood pressure, the pH level, the lactate, and after receiving a fluid bolus, it was fairly responsive. Number 2, the patient's blood pressure is low. Again, after receiving a 2,000 milliliter fluid bolus, the BP was less responsive, and also you still have the altered pH and altered lactate. This is signs of septic shock. There's going to be a lot less response by the body because they're running into that compensatory withdrawal. Number 3 is sepsis. That's the easiest one. The patient's blood pressure is okay. There's no change in blood pressure in sepsis. This is the signs you need to watch out for before the patient gets into severe sepsis and septic shock. So you got a acidotic pH, but it's on the lower side. It's not as acidotic due to the lactate being a lot lower than 4. And you're going to have an elevated temperature and elevated white count. So that's the first sign of SEERS. And then the second sign leading to sepsis is the lactate or pH. So how did you do? If you did well,
Hopefully that was a little bit helpful. This CCRN review is from YouTube. So he's got a whole bunch of videos that go over each chapter if you're looking for a little more information when we're done with these sessions. His voice a little bit sleepy making, so hopefully you guys find my voice a little more exciting than his, but definitely a good resource if you're looking for additional information beyond these classes. So one of the other questions was talking about SvO2 and the use of SvO2 during shock states and the use of oxygen at the tissue level. So we're going to spend a little bit of time talking about this. Some of these slides, if you've been through my orientation, might look a little bit familiar, but it looks like pretty much everybody has not. So hopefully these will make me look like I'm smart and make you guys a little bit more knowledgeable at the end. So when we're talking about how much oxygen is being used at a tissue level, what we're really looking at is the SvO2. So who can tell me how we get an SvO2?
From a swan.
Yep, you can get it from which part of a swan?
It's the yellow part, I forget what it's called, but it's the mixed venous sat.
So SvO2, we're not going to look for mixed venous. An SvO2 we can actually get from a CVP port of a regular central line. So you don't need a swan for this. And what we're talking about is the amount of oxygen that's coming back to the right atrium after the blood has circulated throughout the entire body. And so what that will tell us is how much oxygen is being deployed at the tissue level. So if you assume that the hemoglobin that leaves the lungs and goes out through the left ventricle into the aorta is 100% saturated, what I want to know is how much oxygen is being taken up by the tissues when the tissues are working and then being returned to the right atrium. So that's what I'm going to use when I do my SvO2. And it comes right from a venous blood gas. And so I'm nerding out a little bit. For those of you who were here last week, you may remember a little nerd stuff. So we're going to continue on the nerd profile here. But it's just a review. We've got oxygen diffusing from the lungs into the pulmonary capillaries, and you've got carbon dioxide flowing out. And then down at the tissue level, we should be seeing oxygen going through to help with ATP production, and then CO2 diffusing out. So I found this graphic kind of helpful because it's fun to look at when we're talking about how much tissues are actually using. And so this is coming from the lungs. You can see that the hemoglobin is 100% saturated. So every binding site on a hemoglobin has an oxygen molecule attached to it. And so this way we can actually see all 4 binding sites are bound We're going to send it out through the heart, deliver it out to the tissues. Here at the tissue level is where our oxygen is going to be diffusing out to those cells, down into the mitochondria. And when we're having our hemoglobin moving back to the right atrium here, we should see 3 of the 4 binding sites should still have oxygen molecules attached. So when you draw your SpO2 on a healthy patient who doesn't have sepsis, you should see it to be about 75, because that says that 75% of your hemoglobin sites are saturated. And so when we're talking about a patient who's in a shock state or in a septic state, and those tissues are either working in overdrive, they're dying and producing additional lactic acid issues, we're going to see other tissues try to compensate by pulling a lot more oxygen off of the hemoglobin. And so in the next slide, I'll show you what those sort of numbers might look like depending on what's going on with your patient. So it doesn't just have to be shock or sepsis. These are all things that can impact your patient's SpO2. So when you're drawing your venous blood gas, if it's something that your provider is ordering, these are other things that can impact your SpO2. So if you're worried about sepsis or you're worried about SIRS, make sure that when you draw your blood gas, you haven't done one of these things, like done an entire bath and then done your labs, or done aggressive suctioning, because that will actually drop your SpO2 and you might get a false reading. So down here on the bottom right, you can see normal extraction, you're going to have an SpO2 of greater than 75. When we're talking compensatory, so that compensatory state of shock, you're going to see an SpO2 between 50 to 75. Once we move down below 50, you're talking about the onset of lactic acidosis. So now it's extracting so much oxygen that when those red blood cells return to the lungs, they can no longer replenish those binding sites up to 100%. So we're sending less saturated hemoglobins out to the body, and then the body is still trying to extract a lot of oxygen off of those hemoglobin sites. So you'll start to see lactic acidosis because there's not enough oxygen circulating. Anything less than 25, and we're talking about cellular death. So things that you might do, especially if we're talking about case study scenarios for the CCRN, things that you might do to try and increase the supply if you've got a patient who is going to be your sepsis patient that you're learning about, increase their FiO2. So if they're intubated, increasing their FiO2, same thing on high flow, making sure they have adequate PEEP, and then making sure that they have the adequate ability to actually transport that oxygen. So making sure their hemoglobin level is up, and then that oxyhemoglobin dissociation curve. I know there was an ask to review the oxyhemoglobin dissociation curve again this week, and it's on the end of this PowerPoint. We'll talk about it a little bit. So just as a refresher, we've got our black line here. This is our ideal state. Our increased affinity here, so it's going to hold on to the hemoglobin and not be used at the tissue level. So if we have a low temp, we have low DPG, or we've got an alkalotic state, we're going to see that the oxygen is going to hold tight to the hemoglobin, and it's not going to want to release at the tissue level. The flip side being that if you've got a fever, increased DPG, or increased hydrogen ions, so you're in an acidotic state, it's going to have decreased binding, which is great at the tissue level, but not so great in the lungs themselves when we're trying to bind the oxygen molecules to the hemoglobin. Making sure these septic patients, you might be asked about cardiac output. So making sure that you know that cardiac output's related to stroke volume and heart rate, and the adequate ability to transport that oxygen. Other things when we're talking about tissue consumption and oxygen consumption at the tissue level, making sure that you've got controlled seizure activity, that SNS simulation is down, making sure if your patient's febrile, that the fever is getting controlled. More of these are less CCRN based and more based in reality, which is treating the infection, controlling fever, making sure your patient's comfortable, and decreasing any stressful things in the environment. I really think this graphic is very helpful when thinking about all the components related to oxygen consumption and tissue. So our goal, there we go. Our goal is to have a balance of end organ perfusion and cellular oxygenation. And so these are all the components that you as the nurse are thinking about and things that you can control. So the demand side is pretty simple, right? Either you're controlling your patient's temperature, cooling them off or warming them up, making sure that they're not having any sort of unnecessary physical activity, or you're spacing out their physical activity, and then controlling their stress. The bigger issue is the supply side, which is all of the things on this side of the graph. And so when you're answering questions that are related to oxygen consumption at the tissue level, really the only things you're going to have to focus on are these over here. So infection, perceived stress by the patient, physical activity and temperature, and the ways we can correct it. You're going to increase the oxygen supply, either by having more oxygen available or circulating the available oxygen with cardiac output. Questions so far about SVO2 or oxygen use at the tissue level or sepsis?
I have a question.
Sure, Carrie.
So I think it was in Kathy's lecture on hemodynamics that I just want to make sure that I got this down right and I didn't like dream it or something. If you're drawing an SVO2 from a central line and you draw another one from a peripheral, they're going to be different. So you should always draw it at the same location, correct? Okay.
Yes, and why would they be different?
Because if it's more peripheral, you're losing less than when it travels back to the heart, where it will be the very last spot, right?
That is exactly right. Yep, so we can do peripheral VBGs, but as Carrie said, you're not going to have all the oxygen that's been removed yet because that blood's still circulating. The last moment and the most accurate moment would be right in that right atrium before those blood cells shoot off to the lungs to get oxygenated.
Thank you.
Yeah. Are you raising your hand, Inga, or just moving your arms around? Okay, just checking. Alrighty, so there was a question about paralytics and propofol. Well, let me tell you, that sent me into a tizzy today. It required a consult over in the MICU with Dr. Gray, who was the attending, and Phil, and I consulted my nurse practitioner over here to the right to find out why the textbook said that there was a do not paralyze section about propofol. So all 4 people concurred, it's a typo. And so I scanned in the pages so you can see them here. So for Precedex, it says do not paralyze while they're on decks, where this just says do not paralyze without any additional information. Phil and Dr. Gray could not come up with any reason why you wouldn't paralyze a patient on propofol. Certainly you wouldn't do it on low-dose propofol, but the conclusion we all came to was that it should say does not paralyze, not do not paralyze. So that was all the insight I can provide for that question. Sorry. Phil's recommendation was that I email the publisher. So stay tuned. This, I don't know how well this is showing up on the screen, but this is the rough properties of the vasopressors. Talks about what the target is, whether we're talking about alpha or beta, effect on the heart rate, effect on SVR, cardiac output, blood pressure. It answers a little bit more than what the question was as far as do certain pressors impact preload and afterload, but I think it's kind of helpful to just see what the impact of different cardiac meds that we use are on different parts of the heart and the vessels as well. So again, this is more for your personal reference. I just kind of like the way this was organized. emcrit.org has a ton of great graphs like this, and they've got a pretty good sense of humor. If you take a look at the bottom right, you'll see what their main use for dopamine is. So hopefully we are not in a zombie apocalypse yet, but if we are, feel free to use high-dose dopamine. So anyway, I think that this is kind of a helpful back pocket piece of information to have when you're starting to do stuff for studying for meds specific stuff for the test. So whether you're doing it for the cardiac section or the multi-system section, I think that this is kind of a helpful chart for us to have kind of just in the back of our minds. And so to answer the question about preload and afterload effect specific to pressors, so vasopressin, you're going to see an increased SVR, potentially an increase in preload, and then the others, you'll all see an increase in SVR and increase in preload. Why do you think that is? Why would you see an increase in systemic vascular resistance on pressors?
Vasoconstriction?
Yep, thanks, Inga. Exactly. And then why would you see an increase in preload?
Sarah, what was the question?
Why would you see an increase in preload if you've got a patient on pressors? So Inga said we're going to shrink down the vessels, right? So we're going to shrink down the size of the arteries and veins, depending on what we're using, in order to force blood to go back to the heart, right? So not only are we going to increase the amount of resistance the heart's going to have to fight against, because now it's going to go fight against pushing blood into smaller vessels, but it's going to then move that blood back towards the heart. So you're going to increase the available blood supply to the heart, so to first circulating volume. So you're going to increase your preload. So the lovely oxygen hemoglobin dissociation curve. The reason I am bringing it back up is just to make sure that everyone felt comfortable with it. I know there were some questions about it from last week, and then there was one popping up this week. So when we're talking about reduced affinity and increased affinity, what we're talking about are these heme binding sites here, where the oxygen can actually bind to the 4 sites of the red blood cell. And so if you've got a patient who has an increased temperature, it's going to actually alter the proteins here, and it's going to make the oxygen less likely to bind. And the same thing when we're talking about a decreased temperature or a left shift, the oxygen itself is going to bind more readily to these sites, but it's going to create a stronger bond at this level and not want to be released into the tissue. And so you can see when we're talking about a perfect curve here, it doesn't matter what our PaO2 is. Once we hit about 60 to 80, we're not going to have that much of an impact on our stat, assuming we're in a perfect state. I don't know about you, but I didn't care for too many perfect state patients when I was taking care of patients in any of the ICUs. And so if you've got a patient who's cold or alkalotic, you're going to see that you're going to have a PaO2 of 40 to 50, and you're still going to have a better stat than you would if your patient was acidotic or febrile, where you're going to have that PaO2 of 40 to 50, and you can see that your stat is really going to stink at that point, and you're looking at about 60%. So really the goal is to get that patient to stay right along this curve. And so by doing frequent blood gases, making sure we're achieving normothermia, we're actually able to make sure that the oxygen can bind to the hemoglobin in the lungs and then can be released once we get to the tissue level. Any other questions for today? Comments, concerns? Is this helpful? Okay. So that's all the material I have for today. I think for next week, if it's okay with Julie, I think we'll move on to neuro, and I'll check with her. But then we'll meet from 3 to 5 next week to talk about neuro.
Sounds good. Thank you, Sarah.
Thank you, Sarah.
Yeah. Thank you for participating today.
Thank you.
You.
Sarah.